So my name's John. I'm here in Winnipeg, Manitoba, Treaty 1 territory, home of the Anishinaabe, Cree, Oji-Cree, Dene, and Dakota communities. It's also the homeland of the Métis Nation. We're here today to talk about type 1 diabetes and exercise. And for those of you that aren't aware, Diabetes Action Canada is a SPORE network, patient-oriented research network that involves scientists and patient partners. And for this aspect of the network, we're really interested in co-designing the next set of clinical trials or experiments with patient partners. And so we're hosting a series of webinars throughout the next 2 months that will help us get closer to what we're calling a hackathon that'll be held in probably May, where we'll take the information that we've gathered over the last few months, bring it together and co-design some trials. We had our first session yesterday with the D1 Now group in Ireland, based out of Galway, and they presented on their experience engaging young adults with type 1 diabetes in some engagement strategies and in a network, and then co-designing a clinical trial. And so that'll be up on the Diabetes Action Canada website, and Krista can help us out with that link later on. So without further ado, I'll turn it over to Dr. Dessi, and I'll let you introduce yourself. And Mike, I'll also ask that you introduce yourself, and over to you. And I may put some people on mute if that's okay. And we'll save questions for the end. Thank you.
Sounds great. Hi, everyone. Nice to see you all. My name is Dessi Zaharieva. I am a postdoc currently working at Stanford in pediatric diabetes and type 1 diabetes specifically, and exercise. I did my PhD and master's with Dr. Mike Riddell, so my good pal and colleague. So it's really great to be able to present together, even when I am all the way in California now. So looking forward to it.
Thanks, Dessi. Why don't you pull up the slides that we'll present, and I'll just do a quick introduction.
Absolutely.
On who I am. I am a researcher in Toronto who has a strong passion for exercise and diabetes. I was diagnosed with type 1 at the age of 15, and I have a boy named Sam who has type 1, I guess because of my genetic gift to him. We are thrilled, Dessi and I, to just share a few slides about some of the things that we have discovered, both as patients living with type 1, but also as researchers living with type 1. And, you know, Dessi is a real champion when it comes to exercise and her own self-care, but also a real champion in this emerging area of the closed loop system and how to best manage your diabetes around sport and exercise with closed loop. Dessi's done some incredible sporting events, including getting a bronze medal for Canada in mixed martial arts in a tournament in Bulgaria, which is the birthplace of her parents. So we're just going to be highlighting some of our research. It's important to realize that the field of exercise is, and type 1 is growing, and there are researchers around the globe who are doing great research in the area. But we're just going to today focus a little bit on some of the studies that Dessi accomplished during her PhD work and what our vision might be for the future. But then we want to leave some time at the end for open discussion about some of the successes and challenges you might have if you're living with type 1 and trying to exercise for health or for fitness. And the rest of you who don't have type 1 are diabetes researchers or maybe exercise fanatics or both, like John is and Jane are. So I'll leave it to Dessi to get started. Dessi, why don't you drive most of the slides, but if I can just do maybe that first one with a picture of us.
Absolutely. So thanks, Mike, for the introduction. You're always speaking so highly of me. So we're going to present basically today on strategies for exercise with minimal carb intake for weight loss and exercise with automated insulin pumps. It's basically a mouthful. It's a lot we're going to cover. And the whole point is that there's a lot of ways that we can exercise with, you know, eating carbohydrates. We'll discuss kind of different strategies, but the idea of being able to exercise with minimal carbs kind of shifts and gives us a different idea of how to exercise safely.
So as I mentioned, I was diagnosed at the age of 15. I think, Dessi, you were diagnosed at around, was it 9 or?
7, close, yeah, 7.
And so for both of us, you know, trying to be physically active with type 1 as a youngster, we probably were consuming a ton of carbohydrates for the different sports and activities that we did. I remember that I basically never did any insulin adjustments. I just would pound apple juice and orange juice and just keep going. But over the years, I think Dessi and I have both realized that that's not the only way to tackle exercise, by having extra carbohydrates. And there may be, for performance or weight control reasons, where you might want to have some days where you have more carb than others. So the goal really is to highlight in this particular talk, like, one approach. But I must tell you that a lot of athletes with type 1 still just power through their exercise by just consuming carbs. And some of them are, Team Novo Nordisk athletes who are doing exceptionally well with very high carb intake. So I don't want you to think that we are low carb zealots by any means. Dessi may share some stories about how she cycles through high and low carb diets for different reasons. And I can share, my thoughts on that, but this has a bit of a slanted view on trying to minimize carb intake for exercise. And I just want to say that the last several years working with Dessi has been really rewarding for me, I think more personally than even professionally, even though she got me 25 more articles on my CV. She actually has supported me in so many other ways as a good friend living with type 1, a confidant that I can share my frustrations with, because we all need that when we're living with type 1, but also some of the strategies that she's come up with, personally, that we've tested in clinic and laboratory studies. So Dessi, can you believe it? A quarter of 100 papers published so far together, I think.
I know. I was just thinking, I've never seen that kind of written out until you wrote it. But then I also laughed that I'm bringing you down. Like, your many hundreds of papers is where you're at. And I'm
191, but who's counting? Who's counting?
Right?
We're not counting.
25. I guess I got to step up my game to catch up to you. But yeah, that's pretty awesome to see. We've done a lot together.
Dessi's not the only one who's padded my career. I think Jane padded it too. So thanks, Jane.
Absolutely. So I don't want to spend too much time on objectives. Some people just like to see kind of what we're walking through. So we'll talk a little bit about exercise and type 1, some strategies with minimal carb intake. And again, with automated insulin pumps, a little bit different shift on how to exercise safely. And then case studies. For me, it's kind of important to be able to share my personal information on how I, practice what you preach, but also sometimes you're unsuccessful. So those are kind of important too, and some conclusions. So I do have to give Mike the credit for this, because he sort of remade and revamped this basically slide, but it was taken from the CSEP guidelines. So online you can find these guidelines. But to me, it's really interesting because even working now in pediatrics, there's different guidelines for kids, but I often ask people, like, do you know about the guidelines for physical activity? And many people, just going back to the basics, don't necessarily know all of these things that we are kind of suggested to be doing that would be healthy and good for us. For adults 18 to 64, kind of thinking of these 4 S's: sweat, step, sleep, and sit. Sometimes it's nice to just hear them again, because we know, sure, we should be physically active, but there's more than that. I think a really big one, especially now during this pandemic, is actually the top one on the right-hand side, where you see sit. That whole like sedentary behavior is trying to limit exactly what we're doing now. Unfortunately, sometimes with our jobs and with what we do, sitting in front of a computer, those hours have increased and unfortunately do take up quite a big chunk of our days. So again, the goal is, if we are spending all this time sitting in front of a computer, at least the other 3 areas maybe are an area we can focus on, making sure that we get our 7 to 9 hours of good sleep quality and on a regular basis. I can definitely say, like, again, practice what you preach. If this is what the guidelines are suggesting, I can say I don't do those things. I don't necessarily get 7 hours of sleep a night. And so I'm at fault too. I know we can all work towards being better, but I can say that personally as well. So steps as well, just trying to get light physical activity as well, several hours of light physical activity, just including standing. So, maybe something we can do at the end of this is just get a little standing in and do some air squats, because honestly, sometimes just sitting at a computer can be really tough. We don't all have the luxury of, a standing desk or a walking treadmill desk, but it would be a nice thing if we could all have that too. And then sweating, kind of what the guidelines are of moderate to vigorous physical activity. We often hear that MVPA, that we should be doing as adults 30 minutes of MVPA per day, and basically 150 minutes per week. suggested or more. Of course, if you do more, that's even better. That's great. If you can do 200, 250, whatever you want, exercising more is great. But just trying to get that 30 minutes per day, that would be kind of something we can discuss at the end, like how many people, especially during the pandemic, are actually getting that. For me, like I have a watch that constantly reminds me to stand up, to move, and I'm not getting those 30 minutes per day. So it's a challenging time for everyone. I think it's important, like Mike said, to have kind of a confidant and a person or people that you can, like a network like this, to be able to chat with and share ideas on how we can increase our daily steps, our physical activity, just to get to that kind of, you know, those 4 things of sweat, step, sleep, and sit. So this is, you know, kudos to Mike. I use this in basically every presentation. For anyone that's seen me present anywhere, or, you know, Mike present as well, this is kind of our go-to figure. And, you know, we're really grateful to have this figure to share, because I think it really nicely illustrates how challenging exercise can be with diabetes. And a lot of people don't really know that different types of exercise can cause different responses to our blood sugars. And, you know, a lot of our research is now focused on trying to eliminate maybe hypoglycemia, as it's a big barrier, a leading barrier to exercise. But then we don't really focus on some of the other types of activities that we see that can impact our blood sugars as well. So just to kind of orient you, if you haven't seen this figure, looking at the time increasing on the right-hand side towards the right on the x-axis. And then as we see more intense, kind of high intensity, short duration type activities, more often referred to as anaerobic activities like sprinting and powerlifting, these types of activities can tend to cause our blood sugars to rise. Increases in adrenaline and epinephrine, lactate, these kind of things contribute to a rise in blood sugars. So then we move over to kind of the purple area. So we're looking at more mixed aerobic and anaerobic activities. These ones tend to cause fewer fluctuations in our blood sugars. But then we talked about kind of that blue area, which is a lot of the research is focused on this, these more sustained, longer duration, but kind of lower intensity activities. Some people think that just because it's, you know, a marathon run, that's something that would be a long duration activity, can lead to kind of hypoglycemia, or this kind of trend of lower blood sugars going down. But even just briskly walking or going out to the grocery store for an hour or two, we don't always have to think about it as, you know, some elite performance or elite athlete type activity of doing a triathlon or marathon running or something that's 6 to 8 hours of activity. For me, like we always refer to it as the mall low of just going out to the grocery store on a Sunday. If I'm doing my Costco run, my blood sugars are always dropping if I'm not really prepared or thinking about that. And I don't know about everyone here, but oftentimes you're not pre-planning when you're going to the grocery store. Maybe it's like a Sunday task, and then you realize, well, I guess now for me, I didn't really pre-plan what I'm doing. And if you have diabetes, you kind of know that this is an increasing challenge of kind of the likelihood of hypoglycemia being higher. So here I just wanted to touch on, again, it may not seem as relevant to like the low carb idea of what the presentation is, but going back to the basics of understanding how much do healthcare providers know about exercise? And, you know, there's been a lot of studies that have kind of looked at this specifically around type 1 diabetes research. We know that there's a number of challenges that have been specified in a number of publications, but also just asking kind of medical providers and healthcare providers how they feel about their exercise knowledge. IFPAD has put out a really great kind of survey to try and find out more about how much do we really know, and do we feel comfortable kind of giving knowledge and education to patients with diabetes. And what we found in these kind of studies is that there's a lack of knowledge, there's unclear guidelines, insufficient training on exercise and diabetes, and lack of time to kind of cover these topics. To me, this is really important because we kind of need to do something about this. If our providers aren't able to kind of give us the knowledge that we need as patients with type 1 diabetes, then we're kind of at a loss, right? How are we supposed to know what to do? And if we can't even get the information from the sources that have it. So then some recommendations were made in more recent publications of like, how do we improve this moving forward? Our providers need to know more about exercise and diabetes and at least get it sooner. I think that's what the big kind of take home was. Increasing that education during medical training, increasing the accessibility to these online resources, and increasing access to success stories. So if your provider is able to give you kind of success stories, they can pass those on to other people in the clinic. These are all kind of strategies because if we can start with the providers and then be able to work our way to getting that information to patients, they will hear more of it because we'll increase that knowledge and confidence around giving diabetes and exercise resources and information. This was just kind of a quick plug at JDRF Peak has really made a great resource online of, you know, performance and exercise and knowledge for type 1 diabetes. There are free resources you can find online that are really great, and just even the way the videos are made are easy to follow and kind of more interactive and fun. For me, it's kind of hard to sit and read a journal article all the time, and I know that for some people that's not really the best way to kind of absorb the information. This is what it comes down to: is these guidelines get put out, but then people say, I don't know what the newest guidelines are. Like every couple of years, new guidelines come out, but maybe providers aren't getting those sent to their clinic. So kind of looking at these online resources is another way to kind of, they're always there, and JDRF Peak does have a great kind of resource guide online. So now we'll kind of talk about some strategies for exercise, again, with minimal carb intake for weight loss, but also focusing on other areas too. So it's not always about minimal carbs as being kind of the best way to exercise, but it is something that we often don't focus on. So it'll be a little bit more of our focus today. So this was just kind of put together again using the information from the guidelines, but made hopefully a little bit easier way to kind of interpret the information that we see. So the guidelines suggest blood glucose starting points for exercise, and it's important to kind of have this idea of where should we start to exercise. And if our blood sugars are above or below kind of what these recommendations are, what do we do in these scenarios? It's always important, because instead of telling someone you should be in a certain range, well, in reality, for example, even just seeing this figure or this table, on the left-hand side, we kind of have blood glucose levels in ranges. And then in the middle panel, we have different types of intensities of exercise. The middle panel shows aerobic or low intensity exercise, and the right-hand side shows aerobic or anaerobic or high intensity exercise, and sort of what the differences would be if your blood sugars were in those ranges. And I think we've talked about this quite a bit, and I know Dr. Yardley and I have talked about this too, of guidelines even saying like, you know, up to 15 millimoles per liter. In fact, working in pediatrics, we often see that kids, for example, have glucose levels well above that range. And it's important to not say that exercise should be avoided. There's these kind of guidelines that give us safe starting points. By checking ketones and understanding if ketones are small to moderate, then light intensity exercise is actually okay. You know, it may include considering a 50% correction bolus before exercise, but avoiding exercise isn't necessarily the best thing that we should do. And in fact, like many years ago, doctors and providers would just suggest if your blood sugars are above this range, don't exercise. When in fact, we kind of know through the literature now that if ketone levels are low or negligible, basically, even with blood sugars that are elevated, it's okay to start exercise. If you think about it, I don't know if anyone with type 1 diabetes has done this, taking kind of a bolus of insulin versus walking, or if you do those two things combined, you'll have different responses. And, you know, the importance is maybe not considering anaerobic or high intensity exercise when glucose levels are that high, because as we've shown kind of in the earlier slides is that glucose levels tend to rise with these types of activities. So maybe starting with that aerobic or low intensity exercise, and then eventually when glucose levels maybe are more in range, then we can switch over to doing something more high intensity or mixed. So this table kind of illustrates if you're in a certain range, what are some suggestions and what are things that you can do. Most importantly, kind of those in range areas, anywhere between 5 millimoles and 15 millimoles for exercise are generally safe to do aerobic or anaerobic, but just understanding we may see different responses. Sometimes our blood sugars will go up and sometimes they'll go down. And depending on where we are in that range, we might see different responses. But I guess most importantly too, if glucose levels are below kind of 5 millimoles per liter, regardless of the type of exercise we're considering doing, low or high intensity, usually carbohydrates will be needed. You know, maybe if you're doing low intensity exercise or aerobic activity, more carbohydrates may be needed than if you're doing something that's higher intensity. So here I just wanted to kind of touch on a recent publication that came out looking at basically glucose management suggestions using continuous glucose monitoring or intermittently scanned glucose monitoring as well. We haven't really had any papers that have come out to give us more ideas of what to do based on trend arrows. So as more people start wearing CGM and we're trying to push towards that being as a standard of care, especially in pediatrics, we need to have a better understanding of what we can do for exercise to keep our glucose levels in range. But using those trend arrows can be another way to sort of, you know, make it easier to figure out when do we need to supplement with carbs, or when do we need to kind of stop exercise? When is it safe to exercise? So this table kind of nicely illustrates those similar ranges that we just showed in the previous slide, finally incorporating the idea of these trend arrows. You know, if we see glucose levels in a certain range, depending on the trend arrow, we may do something different. And then there's an action that's now associated with it. So being able to understand sort of where your glucose level is, if you are wearing CGM of some sort, then to be able to look at those trend arrows to make a consideration of what the next action should be, whether you can start the next exercise or you should kind of postpone the exercise. This was a really helpful article that came out, or position statement. So again, depending on the trend arrow, activity type, duration, and intensity, carbohydrates may not even be necessary. For example, in that higher glucose range, it may be safe to proceed, especially if we see a trend arrow kind of flat or up. It may be a little bit safer to start exercise without needing carbohydrates. So kind of supplementing the glucose level that we see with the trend arrow can be a lot more helpful for people. And Mike, I don't know if you had anything to add to here.
Well, all I can add is that this is about as practical as trying to carry around a car in your backpack. We know,
Absolutely.
we know that these
Absolutely.
tables are difficult to read, awkward to use in the field. Like you'd be like a quarterback where you'd have all the plays on your forearm. But I think for me, the bottom line is this kind of points to a threshold of needing carbohydrates when your CGM says that you're below 7 and you have a downward trending arrow. That, other than that, these tables are a bit busy and hard to read, and I think you have to go on your own experiences. But for many of us, when we look at our trend arrows and we see that we're dropping and we're in that zone that's pale yellow there of less than 7, that's kind of when we need to think about consuming carbs if we're in an aerobic event. Because in reality, the sugar might be even a bit lower than what the CGM says it is, and it's probably going to drop for the next little while. So again, I realize that these tables are not that practical for us as patients living in the field, but at least we've tried to come up with a consensus on what to do if we do see them. Thanks, Dessi.
So it's nice to have Dr. Yardley here. I could just get her to hop on and present this slide for me, but I will do my best to kind of share her information because I have quite a few of her slides on here of her wonderful research that's been done on exercise in type 1 that has kind of opened our eyes to understanding how complex, you know, diabetes and exercise really is. There are so many factors that can impact what happens to our blood sugars. And I think at the end of the day, we need to kind of bring that back to, we can say that, you know, blood sugars are going high or low with exercise, but remembering kind of all of these other factors that we maybe didn't even consider, you know, recent hypoglycemia, the time of day of exercise, when did we last have carb intake, the exercise intensity that we're doing, and all of these other kind of variables and things that are mentioned here are really important. But kind of a really important one that we often forget about or don't think about is fitness level of individuals, you know, the sex and the age of individuals. We tend to see, you know, some trends and some things that are common in, you know, for example, young, fit individuals or elderly individuals in terms of glycemic responses, but there's not enough research out there to tell us kind of confidently that this is what will happen to each person, depending on what category you fall into and looking at these specific variables. So I think ultimately what it comes down to is there's a number of things that can impact our blood sugars, going back to, you know, what these things are that can impact our glucose levels and trying to target what some of these issues may be. For example, if you had a low blood sugar, kind of thinking back to when was your last hypo episode pre-exercise? Was it an hour before that? We know kind of the effects of antecedent hypoglycemia can come on even stronger the next time you have a hypoglycemic episode. And again, we'll talk about a few of these in a bit more detail. For example, the time of day of exercise is really important. More research is needed, but based on the evidence that we have, we know that all of these factors can contribute to what we see in our glucose responses.
They also become very good excuses if we can't explain what happened on a given day. Well, it might be that my menstrual cycle is different, or it might be that I'm an older male, or it might be that I exercise in the morning. So we don't fully know how these things interact, but we suspect they probably do. And I think sometimes clinicians just say, well, it's too difficult for you to control your sugars because all these variables might be different on a given day.
Absolutely. So again, this is some research that was done out of Dr. Yardley's lab looking at fasted exercise. This was a really important paper to come out to look at morning fasted versus afternoon exercise. And just that key word that I bolded and colored there is fasting, of understanding kind of what glucose responses could be when morning exercise is being done in that fasted state versus in a fed state. So this kind of figure illustrates CGM glucose. We can see the glucose levels on the y-axis, and then on the bottom we can see time, and exercise is kind of shaded in that dark gray. And importantly, what was done in this study, it was a small subset of 12 participants that did a randomized crossover design. So kind of did both arms, again, looking at morning and then afternoon exercise. We see different glucose responses. I think a couple of things to just kind of point out in this study that were really important is that, glucose levels did start a little bit higher in the morning. They weren't significantly different. So that's kind of important to point out too, because sometimes people say, well, how can you compare this if, your starting glucose levels are different? Well, we kind of have an idea of that morning exercise, why glucose levels are higher. If we think about sort of that dawn phenomenon and impact of growth hormone that can cause our glucose levels to be a little bit higher in the morning, this may be kind of one of the reasons that we see glucose levels starting a little bit more elevated in that first group in the morning. So we tend to see in this study that glucose levels were rising in the morning, and then in the afternoon, glucose levels falling. So even just understanding sort of fasted exercise, how many factors can impact glucose levels going up, and all of the impacts of hormones, growth hormone, and kind of having this rise in the morning is sort of important in terms of how do we apply this information. If you think about someone that's constantly struggling with hypoglycemia or even just worried about hypoglycemia, oftentimes I'll ask, when are you performing your exercise and in what state? Oftentimes in the afternoon, you can't really be in a fasted state because typically you'll have lunch, maybe you'll exercise a couple hours later. But if you are constantly worried about hypoglycemia, afternoon exercise may just kind of increase that risk of having a low blood sugar later on or even during the activity. So again, this was kind of a first idea of morning fasted exercise may be really beneficial, especially for individuals that are kind of worried about hypoglycemia. And just to kind of specify, this was a resistance exercise study, so not aerobic or anaerobic. This one was basically a resistance exercise for both conditions. And Mike, I don't know if you wanted to add anything.
I was going to ask Jane because she's here. I think that this is such a great follow-up study, Jane, to your earlier work that showed that resistance was a bit safer than aerobic as far as a drop in blood sugar. Did you see any sex-related differences in this particular study, Jane?
Sorry, I just need to get my microphone on there and I'll turn off my treadmill because I'm on my treadmill as I'm listening.
Jane probably wasn't ready to just jump in and start answering questions in the middle, but hey, I love that you're on a treadmill. It's great.
Yeah, my home gym, if everyone's interested, right? We didn't actually have a big enough sample size to look at sex differences in this one, but what we did is we took some of the data from this one and some of the data from my PhD thesis where we used the same resistance exercise protocol. And what we did find was that the men had bigger drops in glucose during that resistance exercise than the women did. And they also had a tendency to go lower overnight. Whether or not that's a true sex-related difference, or if it's just that the men had more muscle mass and therefore burned more fuel, we don't know. At the same time, there's this whole difference of like, should we match people for weight and muscle mass and all this stuff? Well, that's not really practical either because, the distribution of women when it comes to fat and muscle mass is very different than distribution of men. And if we tried to match to find out if it's a true sex difference, we're looking at a little sliver in the middle where it actually overlaps. So, overall, we did find men, bigger drop, more hypos. Is it a muscle mass thing? We don't know.
Well, thanks for being a champion in this field, Jane. You continue to impress us with that important work. And you're also impressing us by exercising while we're lecturing.
I love it.
Anytime that I don't have to talk, I can listen and I can walk.
It's great. So needless to say, there's a lot of great research that's been done that's kind of helped advance us in the field and understanding a little bit more about, how do we do exercise safely, especially in these situations, if we don't want to be kind of increasing our carb intake and finding kind of these strategies for minimal carb intake, considering kind of morning resistance exercise may be an opportunity to kind of see that maybe small rise that you see in the morning or reduce kind of the risk of hypoglycemia that's more often seen in the afternoon. Mike, I don't know if you wanted to kind of touch on this slide. We can walk through it together as well.
I can give you a breather if you'd like. We were interested in one study that we performed in Toronto at LMC, where if we saw a rise in blood sugar levels because of morning intensive exercise, would it be safe to give insulin? And so we had a bunch of type 1ers who were pretty fit come into the lab in the early morning in a fasted state, and we asked them to do a high intensity interval workout that was basically a bunch of intense cycling and some calisthenics. It only lasted a total of 15 minutes worth of exercise, but they had little breaks. And we brought them in on 4 occasions. On the first occasion, or on one of the occasions, they did not take an insulin correction. That's in black. And their blood sugar went up and stayed up actually for the whole day. It gave them hyperglycemia for much of the day. And I was always a bit fearful of giving, insulin after exercise. But in this study, we were brave and we gave either a 50% correction, shown in blue, or 100% correction. Or one of our colleagues suggested, well, why don't we really hit the hyperglycemia with a lot of insulin? We gave 150% correction. So that would mean that if your bolus calculator said you needed 2 units to bring you back down to target, we would actually give 3 units. We'd override the recommendation from the bolus wizard, let's say. And this is what we saw in the blood sugar responses. They came back down to target if we give the full dose shown in green, or the super dose shown in purple. But in reality, if you looked at the amount of hypoglycemia later in the day, that 150%, that super bolus gave more hypo. So we don't really recommend it. We really do think that giving the full correction in the morning is probably okay if you're wearing CGM and you can track your sugars, or maybe a 50% correction. But you do kind of need to correct, because in this study, everyone who didn't take insulin correction in early recovery stayed elevated for the rest of the day, and they had very high glucose levels after meals. And so I think that taking a bolus correction after exercise is safer than taking it before exercise. I would be nervous, injecting insulin before I did a tough workout, particularly if my blood sugars were in that reasonable range. I do give a correction if it's above 15, like Dessi had said in the guidelines. But I just wait till I'm done my exercise. I measure my sugar after exercise, and I just add a bit more insulin to bring me back down. We think that the insulin helps to not only correct the glucose, but it also helps to refuel the muscles with the glycogen that it would have used during the workout. And maybe that might help your performance later on, but that's a bit speculative.
And Mike, one thing I was just going to say is I definitely agree. I think there's always been this thought of like taking insulin before exercise, but one of the slides that we'll show is basically individual variability. One of the biggest challenges with telling someone to do this before exercise is that I think if you live with type 1 diabetes, you very well know that if you do kind of the same thing today and tomorrow, and your blood sugars are the same, and every other condition is the same, our glucose responses somehow will not be the same, or very unlikely to be the same. So I think this kind of goes back to the idea of individual variability is like one of our biggest challenges. And as Jane mentioned, in a small subset of people, we can't really make generalized suggestions to the population of individuals with type 1 diabetes. We need kind of more research and bigger sample sizes to kind of be able to confidently say, this is what you should do.
Agreed. I just wanted to then follow up with this paper that we just got accepted, and it's just been published in the February issue of Diabetes Care, which for us is one of the best journals that we can publish these little studies on. And this study was done by another type 1er, Sarah, who's a hockey player with type 1. And she and Dessi and some other colleagues of ours looked at how could you minimize your carb intake if you're doing aerobic exercise in the morning. Dessi had done a nice study with this type of thing in afternoon exercise, and had shown that if you are on an insulin pump and you turn down your basal rates 90 minutes before you start aerobic exercise, you could attenuate the drop in your blood sugar levels. So we followed up with this study, which was a morning fasted study, and we actually did 2 hours worth of exercise and tried to see how much carbohydrate we needed if we didn't do that basal rate reduction, or if we did. Now this is a bit busy, but the way to understand this graph is that if you're on a pump, you can turn down your basal rate at any time manually if you're in what's called open loop, if you're in a regular pump. You might turn it down 90 minutes before the exercise, like in blue. You might just turn it down as soon as you start exercise, that's shown in red, or you might just not turn it down at all, that's shown in green. So we tested these 3 approaches because they're common approaches. Like, I don't always remember to turn my pump down before exercise. I might forget, or I might just want to go for a run and I might just turn it down when I start my run, or I might just forget to turn it down altogether if I'm in the store walking. So I think this is a common approach that people have. And then we quantified how much carbohydrate it needed to kind of keep their glucose levels afloat when they did these 3 different approaches. And what we found is that if you turn the pump down 90 minutes before you start exercise, you really don't need any carbohydrate. And if you want to flip back up, Dessi, just for one more second, you can see the amount of carbohydrates on average we had to give in these little boxes up here. So we needed about 40 grams if you didn't turn down your pump. We needed about 30 grams if you turned it down, but at exercise start time. It didn't need really any grams if you turn it down well in advance. And the next plot just shows the blood sugar levels.
I was just going to touch on this as well is, you know, we published kind of the original idea of 90 minutes before exercise, turning the basal rates down in open loop. And, you know, with closed loop, things are a little bit different, which we'll touch on a little bit later. But, you know, it always comes back to, I would present the data and people always would say, who remembers to do this in 90 minutes before exercise? You know, like, I don't even know what I'm doing in 90 minutes time, let alone like pre-planning for exercise. Maybe I do know I'm going to exercise in 90 minutes, but I'm not going to remember to turn down my basal. So I think there's a difference between doing the research to kind of show the responses and show that ultimately it does take a long time to get our basal, our insulin levels down in our body that are currently circulating, versus kind of a practical standpoint. Exactly like Mike had mentioned, you know, we put out guidelines. They're not necessarily the most practical. We put out these studies that maybe are not the most practical, but just to show that where we're at in diabetes research right now is that currently pre-planning for exercise is kind of the safest approach to attenuating that drop, but we understand that, you know, it's not necessarily the most feasible or practical approach.
Right, but I think, you know, if you're really trying to cut calories and to cut weight, you know, you kind of have to think ahead by 90 minutes because, you know, 38 grams of carb, that's 150 calories that you had to consume when you're exercising. And so if you're trying to cut calories and cut weight, I think turning down that pump well in advance would help a lot. Here's the blood sugar levels. So they were basically stayed in a reasonable range. We published this in milligrams because it was a US journal, but the dashed lines sort of show what your blood sugar is when you're in range, let's say between, you know, 4 and whatever that is, like
10.
Yeah, thank you, Dessi. So all strategies kind of work. It's just like, do you want to try to cut your calories and not take carbs? If so, then the blue line's what you're aiming for with that basal rate reduction well in advance of exercise, if you could remember to do it. And if you don't, you know, you can take carbs during exercise. You might need 40 grams or so over the 2 hours if you exercise. So
one thing that I've kind of done to help myself implement this 90 minutes before exercise, like Mike mentioned, we say it's kind of, many people will tell me that it's difficult to remember to do this, especially in pediatrics or with kids. But one thing that we say is, like, there are strategies now with working at home and kind of, you know, shelter in place and through this pandemic of how we can do things. Setting a simple alarm if you tend to exercise around the same time of day is one strategy that really works for me, is just implementing that every single day. I try to have my structure. Maybe not everything in my day is structured in terms of Zoom meetings and scheduled calls, but then one thing that I try to kind of keep consistent is I always exercise in the evenings around the same time of day and set that alarm kind of 90 minutes before so I can just remember. And that's another way to kind of do it as well.
Yeah, and if I can just make a plug for our colleagues in Virginia, I think I see Bayshak on the webinar. They've actually designed a system where if your exercise is predictable, you know, you always are going to exercise at 4 in the afternoon. They've developed algorithms that basically turn down the pump for you without you having to do it. And I think that type of research in the future will be quite valuable. So Bayshak, do you want to say hi for a second? I'm seeing who's in the audience giving a shout out.
Hello. It's really great to see you both here.
You too.
Yeah, and so recently we had this algorithm where we have the ability to anticipate when you're going to exercise. Of course, we needed a lot of data, one month of data. And if the person exercises pretty much around the same time, our system is able to kind of take an action beforehand. And then if the person happens not to exercise, then we make up for it when we realize that the person is not exercising. Yeah, the results were pretty promising for now.
Yeah, that's really, really exciting.
It's also just really exciting to see kind of technology advancements, because to be able to do this, we kind of need to have the data of CGM and understanding when we're exercising. And, now with closed loop systems, things are changing, but we'll kind of talk about that as well, is that even with these closed loop systems, that pre-planning is still required. We often think that just because we're using a closed loop system that can maybe automate our insulin levels, that we don't need to pre-plan anymore because the pump can adjust for us. But these are the exact studies that kind of show, even still, we kind of need to pre-plan. And if we can do that without having to do it ourselves and the algorithm can help, it's really great.
Yeah, we're thankful to all the bioengineers like Beshak who are working in this field. Thanks, Beshak.
Yeah, thank you very much for talking about that.
So just to summarize what Dessi and I have talked about so far, like if you want to cut your carbs, there's a few things you can do. You can try that basal rate adjustment if you're on a pump 90 minutes before exercise. I think Jane's work shows nicely that maybe morning exercise is the way to go if you want to minimize your carb intake, and doing resistance training probably is better than aerobic training if you want to minimize carb intake. We also found that if you do high intensity work, interval work, you probably don't need carbs. You might even need a little bit of insulin if your sugars do go elevate. And I have also found, this has been published more in type 2, but a little bit in type 1, where if you simply go for your aerobic session right after your large meals in the day when your sugars are normally going up anyway, then you don't need to take extra carbs then. So I like to go for my brisk walks after dinner now, which is my largest meal of the day. And I have a dog, so I got to take the dog with me. And I don't need to then take extra carbohydrates because I've already had the carbohydrates in my dinner. And I don't know if Dessi, you can think of any other anecdotes for carb minimization, but these are the ones that I thought of.
Yeah, these are definitely the kind of key scenarios. I will share sort of, my idea of low carb diets. This can be a very controversial topic, or kind of, difficult one to discuss, because there just isn't really enough research on type 1 diabetes and low carb. And then even how do we quantify what low carb is? There's some kind of back and forth about this. I say low carb, I'm not referring to myself as ketogenic by any means. It's not less than 50 grams of carb per day. And if anything, like, that's really difficult to follow for me. So I try to keep my carbs low. And so for me, like below 100 grams of carb is still technically considered low carb based on publications that have come out. For me, just the fewer carbs that I'm consuming kind of consistently, if this is day to day, it just eliminates kind of the increased rise that can happen through eating a large carb meal. So not necessarily is this like minimizing carb, but when I'm not having that during the day, I tend to find fewer fluctuations in glycemia. So I know there is this kind of risk of, hypoglycemia with low carb diets, but that's where I wanted to kind of touch on the fact that for me, low carb, I don't mean kind of ketogenic where it's very low carb. And there we definitely see potentially an increased risk of hypoglycemia, but more research is sort of needed. So that I'll talk about with my case study as well. So this one I won't spend much time on, but we recently published a review paper now that I've kind of started at Stanford working in pediatrics and type 1 diabetes, especially, for me, it was really important around this pandemic to understand sort of what is happening around physical activity. I think everyone is different. Some people like Jane, kudos to you to be able to run during these calls. I don't have that opportunity. I don't have a treadmill in my home, but it would, for me, the challenge is that in pediatrics, we often see kids are no longer doing kind of the structured physical activity that they were doing based on, school activities, because school is now remote. So we see a lot of these situations where physical activity, has gone down in a lot of situations, not for everybody, but it was kind of an important time to put out this paper of, we have some challenges with weight management in youth with type 1 diabetes and obesity, but there are also possible solutions, starting with kind of physical activity and understanding that just wearing physical activity trackers in studies, particularly in non-diabetes, we can see cases where, you know, physical activity trackers can lead to increased steps and increased daily activity with these intervention trials. We're actually doing a pilot study at Stanford right now, thanks to Helmsley Charitable Trust for funding this study, but we are looking at basically understanding behaviors and patterns of new onset type 1 diabetes. For me, it was this idea that when I was diagnosed with type 1 diabetes, I had very little understanding of diabetes. My family didn't understand it. We had a lot to learn. We came from a different country and, you know, English was our second language. Just to understand how to manage diabetes, let alone exercise, was really difficult. So that new onset phase, we know there's a lot of kind of barriers and worries and fears, and just kind of understanding how to manage the condition is one thing, but understanding physical activity is usually kind of pushed off until later on. I know for me, and I don't know if Mike, it was the same for you, but I didn't really have much guidance on physical activity and how to do so until much later in my life. I mean, I would say I was in my 20s when I first started hearing about how to safely exercise. I was already having these, you know, really low blood sugars after exercise when I was competing for Team Canada. I didn't even have CGM at that time. So just the research really wasn't available to me at that time. And now we're trying with the grant from Helmsley Charitable Trust is to be able to implement exercise education in new onset diabetes, because the goal is if we can start educating early on, maybe we can help break down some of these barriers to physical activity, which we know, you know, the fear of hypoglycemia is one of the leading barriers. So that's sort of where we're going with physical activity. We know that the psychosocial approach is really important, kind of discussing healthy behaviors of eating and kind of steering away for emotional driven eating. It's kind of a complex system, but understanding psychosocial approaches and nutritional approaches. This is where kind of the idea of low carb diets and type 1 diabetes, we just don't know enough, particularly in pediatrics, and type 1 diabetes is definitely not an area that's been focused on and published on. So just understanding kind of healthy eating and nutrition, but also understanding that we still need to do a lot more research in the field. And then medications as well. It kind of goes to show that there's a lot of gaps in the field of pediatrics and type 1 diabetes, especially around exercise, mainly because we know that, you know, there are, you know, SGLT2 inhibitors and GLP-1 receptor agonists, and these kind of adjunctive therapies to diabetes that have been especially prescribed for type 2 diabetes, more often now being seen in even type 1 diabetes in adults, not necessarily in pediatrics. So it's sort of this area of we are moving towards doing more research in the field and understanding how we can better focus on weight management strategies. And Mike, I don't know if you wanted to touch on this one, a recent kind of publication that is out from your team.
Well, I think that this one tried to give some targets if you're on CGM, what % of your time you should be in the so-called good glycemic range. But it's a pretty high bar. We think that you should have around 70% of your time in range, but when we looked at a large cohort of type 1s, we found that they were less than 70% time in range on average. But what was interesting is that on days that they were very physically active, they had higher time in range. We had quantified % time in range on 642 active days versus sedentary days. So it looks like on active days, you might improve your time in range, but of course, you might also increase your time below range, which is what we found. The time below range was around 9% on active days and 7% on inactive days. The numbers 3 and 2 are included within those numbers. So it just means that we have to watch for hypo on active days, but overall we should have better target range.
And even just to think about some of the challenges with exercise is the guidelines, basically when we see these stacked bars, recommend 4% hypoglycemia, less than 1%, kind of even below that 54 milligrams per deciliter. But even just understanding that with exercise, we see those challenges still exist, kind of increased rates of hypoglycemia that we need to better understand strategies to manage.
I don't know if people in the audience are trying to get a handle on their % time in range if they have diabetes, but I now look at that quite a bit for me. I don't even do A1Cs really anymore. I just look at my time in range, and I find that quite informative and quite motivating, and sometimes demoralizing on some weeks. But It's a good way to track how your diabetes control is. I don't know if anyone wants to comment on whether they're getting these data from different data sources. Like some people may use Clarity or Night Scout, or they may use CareLink, but I find it quite valuable. Dessi and I are always competing against each other, of course, with our percent time in range, and Desi's always winning.
That's not true. We'll open it up so we can have questions at the end. I just want to make sure we have time to get through these last few slides. So we're just going to look at some differences now with exercise and open versus closed loop strategies. And I'll go a little bit quicker on this just to make sure that we can get through all the slides. But this was a paper that we recently put out as well, another review looking at kind of glucose control with open and closed loop and how to manage our blood sugars with exercise. So I think the important thing for this slide is just understanding that there are still a lot of similarities, whether you're in open loop or in closed loop using an insulin pump. And so kind of contraindications to exercise, having a recent severe hypoglycemic episode of less than 2.7 millimoles per liter. These are considered contraindications based on the guidelines. You know, we say significant hyperglycemia greater than 15 millimoles per liter with an asterisk there, because I think we always need to remember, as I mentioned very early on in this presentation, that it really shouldn't be a contraindication if ketone levels are not elevated. So I think it kind of, you have to look at the next point there of ketone levels that are elevated, that exercise should be kind of delayed or postponed. But if ketone levels are very small and, you know, or moderate even, aerobic exercise is still generally safe, even if glucose levels are elevated. And then just kind of understanding pre-exercise meal boluses less than 1 to 3 hours before exercise, guidelines that were published. Also just looking at kind of reducing the bolus insulin by 25, 50, or 75%, depending on kind of the intensity of exercise. And then the last point of just looking at pre-exercise carbohydrate. So this one looking at how many carbs to have if glucose levels are in certain ranges. So again, between 7 and 10 millimoles per liter, it may be safe to start exercise with no carbs. But then depending on how long the exercise is, you may kind of need carbohydrate supplementation partway through. But then of course, if glucose levels are above 10, always looking at kind of ketone levels to understand sort of what intensity of exercise to consider. But to me, kind of the most important one here is just to understand the differences versus, you know, in open versus closed loop. And so as we mentioned with pre-exercise basal rate adjustments in open loop, our publication a few years ago looking at 50 to 80% basal rate reduction 90 minutes before exercise in open loop, because you have that kind of ability and flexibility to make a basal rate reduction on your pump. But then we've also kind of shown that with more high intensity or circuit-based exercise, pump suspension at the start of exercise is generally safe as well, particularly if it's a shorter bout of exercise. And then with closed loop, kind of the important point here is that we have this idea that with closed loop, it should be able to kind of manage our blood sugars. But really what's been found in many of the studies that are closed loop related in exercise, these exercise targets are still being set 1 to 2 hours before exercise and tend to be the kind of safest, just to make sure that insulin levels can be lower going into exercise. And then another important one when it comes to closed loop is that if the pump is being disconnected from the body, if you're doing some sort of physical sport like MMA for myself, if you disconnect the pump, is just always remembering to suspend it. Because we don't often think about this, but when you're wearing closed loop that's automating insulin delivery, if it's not attached to your body, the pump doesn't know that. So if it's automating insulin, it may be kind of delivering or pulling back insulin, and it's using your CGM values to kind of make that next step of what to do. So then once you connect the pump after exercise, it's not going to know what was delivered or not delivered to the body when it wasn't connected to you. So this is kind of a really key point, because it could really kind of screw around with your blood sugars if you do not suspend it when you disconnect. And then kind of looking at that pre-exercise carbohydrate, if glucose levels are below 7 or specifically below 5 and 7, there's different kind of ranges in open loop between 10 and 30 grams of carbohydrates. But also understanding that in closed loop, there is this aspect of automated insulin delivery. So already kind of the carbohydrates needed, since the pump is already kind of pulling back on insulin when glucose is dropping and giving insulin when glucose is rising, typically you need kind of lower amounts of carbohydrates before exercise. And then most importantly, and I kind of bolded these 2 points, but giving your snack kind of less than 10 minutes before exercise is really important, because I actually just worked with someone yesterday that we talked about, you know, always having the snack 30 minutes before exercise with closed loop. And then they were always kind of going high and then low during exercise. And the reason is if you're taking this kind of free snack or uncovered snack 30 minutes before, as is typically recommended in open loop, the automated insulin delivery doesn't know that you're exercising. So it'll start giving you insulin to kind of make sure you don't go too high because of that snack. So ultimately, it's just important to not do that because you're basically setting yourself up for low blood sugars during exercise. If you have this snack way too early in advance, the system just knows glucose levels are going up. So automatically we'll start delivering insulin to bring you back in range. So just important to kind of give that snack very close to exercise if possible. And then kind of post-exercise meal boluses, doing a sort of bolus reduction in open loop of 0 to 50%, which has been published in the guidelines. But then usually a slightly lower, smaller bolus reduction is necessary with closed loop, again, because of this aspect of automated insulin. And then post-exercise, we've also seen a number of studies that have looked at basal rate reductions of 20% overnight, usually for 6 hours, to kind of protect for that nocturnal hypoglycemia we often see in recovery and after exercise, especially overnight. Now with closed loop, we often say, well, there isn't much you can do. You can't really set a basal rate reduction. So people usually will just go to bed after exercise. But what's important is that actually setting an exercise target may be helpful. So here it says exercise target off. So meaning that your pump should just be working in closed loop with an asterisk in that if hypoglycemia is really common with closed loop, even in kind of overnight, setting an exercise target overnight may just kind of give you a little bit of a buffer and not worry as much about kind of hypoglycemia overnight. So I think we're at our time. So we're just going to kind of get to the last slide and stop sharing our screen so we can do a little bit of a discussion. Sorry we didn't get through everything. I think just kind of one last one to sort of pull up on here to be able to show is that at the end of the day, we know that there are so many challenges when it comes to exercise. The idea of having a lot of circulating insulin, the idea of kind of individual variability. These are all kind of challenges when it comes to exercise and diabetes that I think we need to be a little bit kinder with our bodies and understanding that if we're not perfectly in range and exactly where we want to be during exercise, it's a little bit understandable that we can focus on maybe a few of these components, but it's not always going to be smooth sailing. But hopefully we've given you some strategies to think about. So I'll stop sharing my screen.
Thanks, Dessi.
Okay.
Great job. John, do you want to moderate any other last minute chats or discussions? I'm happy to stay on for a few minutes if.
Yeah, if people can stay on, that'd be great. I'll pass it over to our patient partner group. Whoever wants to ask the first question, go ahead. Thank you for that incredible talk. Denis?
Okay, we'll try with one. Like you said earlier, each day is a challenge to keep on track. And the challenge I have right now is I have an open loop, closed loop. And the problem I have is the insulin on board. And I haven't seen anything about that on the table you shown in the presentation. The presentation was great and I learned a lot, but I was wondering about, I did miss it or?
No, that's a very excellent point. And actually, I would say most importantly, at least for myself, this is probably the #1 culprit. So for me, high insulin on board is basically, regardless of the type of exercise that we are doing, anaerobic, aerobic, for me, the intensity doesn't matter in terms of if we have, say 5 units of circulating insulin and it's in the system already, it just gives us that added challenge. So we didn't really touch on it too much, but a couple of suggestions. Unfortunately, minimizing carbohydrates is not necessarily an option in this scenario because if you have that much circulating insulin, we know that kind of the risk of hypoglycemia is greater. So for me, there's a couple of suggestions. If you don't want to be supplementing with carbs to kind of prevent the likelihood of a hypo episode, is just unfortunately delaying the exercise start time. So with having that much insulin on board, for me, it just helps to either, if I don't want to be eating a carbohydrate snack, is just postponing the exercise even an hour or two, if possible. It's just one of those situations that unfortunately too much circulating insulin, there's no real good answer in terms of, how we can do it without the carbs.
Thank you.
I just have a question. It's Conrad here from Diabetes Action Canada on the data sources that were used. Wondering if you looked at wearable data plus CGM data downloads linked with primary care and admin, or what exactly did you do for data sources?
Yeah, so I think a number of different things. A lot of them were basically looking at CGM and glucose data in terms of physical activity. So for basically wearable technology data, all of that data has been kind of compiled together to look at, it's really difficult because these sources come from different areas. So exactly kind of like you're mentioning. So for example, if we use Garmin data, that data gets pulled to us so we can look at it from the API and we can look at Garmin data separately. We can also overlay that data with kind of CGM, and that's some work that's actually being done with Dr. Clements, and he's also working with Mike as well. So there is ways that we can start looking at kind of multiple variables. So looking at glucose and kind of heart rate, for example. So that's some of the ways that we are kind of looking at the glucose levels. But Mike, if there's anything you wanted to add.
We've been advocating for data amalgamation through things like Tide Pool, but it's not quite there yet. So it'd be nice if everything just downloaded right to one data source, and then you can start to look at the relationships. I think Tide Pool and Gluco are the ones that are closest to this right now with wearables, but they're not widely used in Canada. So it's a challenge. It's a real challenge.
It's a challenge.
Yeah, and then it's something
Absolutely.
that I think we'll see evolve in the next 3 to 5 years based on some inklings that I have on where this needs to go.
I think another important point is just inclusion for us in studies. We try to not do studies that are specific to maybe like one CGM or one insulin pump and one wearable device, for example. If we can try and open that up, because inclusion is, for a wide variety of reasons is something we focus on, especially in pediatrics. That just adds another kind of challenge or barrier, is that now if we have these different systems, even just downloading pumps and how the data looks and how the CGM data looks, it is definitely an added challenge. So like Mike mentioned, Tide Pool is definitely one way that we can kind of get different systems uploaded into one database.
On the flip side, John will be fascinated to hear that we're also going to push diabetes streaming sources to your more traditional exercise repositories like Strava, for example. Like you'll be able to see on Strava what your glucose is if you wear a CGM. And I think that's kind of fun.
I think that's great.
And more and more people will be having access to CGM as they become cheaper. In fact, even more non-diabetics will be wearing CGM, I predict, in the next little while.
And yeah, athletes already are using it, from my understanding. Conrad, did you want to just say something about maybe some of the opportunities coming up within DAC for large data?
Well, that's exactly from my question. So I manage the National Diabetes Repository. And right now we're expanding to Newfoundland and the East Coast. We've got primarily the centralized location, but a big push we have from the AI researchers and mathematic modelers is the push for big data. And so they want the wearable technology, they want the bio data. So we're slowly getting there and starting to bring in patient-reported outcomes and experience measures. So getting their data directly in as well.
We needed. That's excellent. I'm glad to hear that. Thanks, Conrad. That's great. That's great news for all of us.
Absolutely.
Perfect. Great. Yeah, we're pushing for renewed funding and the next phase of the repository. So glad that it's of interest.
Very much so.
I have a question.
Hi, Heather.
Sorry, Hi. I have a question about the study that was done recently, Dr. Riddell, with the hockey player. Do you know what type of exercise they were doing and at what time of day? And how many females were there?
Oh, Sarah's study. Yes. Okay, so that was morning exercise, and it was basically treadmill, brisk walk, or jogging. So it was fairly mild exercise that lasted for 2 hours in the morning in the fasted state.
Okay.
And I think it was, did you ask how many? There was 15 people that were done in that study.
15, and how many? 1-5, I'm assuming, yeah.
Yes, 1-5, yeah.
Okay. And then the, how many females?
Off the top of my head, I'm not sure. I think we always try to do 50-50 as close as we can get, but it's,
It was close.
Okay. It was close to 50-50. And if you're interested in amalgamating, data for your research interest, then just reach out because we'd be happy to share that data with you or Jane or whoever's interested in it. We did actually bring the females back in on separate occasions. We didn't publish that yet, but we did bring them in luteal and midfollicular.
And was there a difference?
Yeah, kinda.
Yeah, maybe not enough.
Made it on enough subjects, yeah.
Small sample sizes, but
yeah, it's tough.
definitely talk to Jane about this and how important it is to start looking at this area. I think anecdotally, we know a lot, you know, of living with type 1 diabetes. Often people will say they have challenges, so we just need to kind of do more research to be able to show it now.
Yeah, I agree.
We have recruited 200 and I think 75 type 1ers now for our larger Dessi project. And so I think that's going to be a rich data source for us to look at these things. But, you know, it's really hard to get all the data we'd all love to have. Like, we are not going to have everything. Like, will we really have what menstrual phase they're in? I don't know yet. So it's a real challenge for some of these questions.
Dessi and Mike, we have a question from Kennedy about which pumps are you using?
Hey, that's not, you're not allowed to ask that.
Yeah, we don't talk about that. No.
We use everything. We sometimes change to 3 in one day, actually. You name it, we've tried them all.
Sometimes with saline going into one to try and look at different systems.
We have tried.
We're our own guinea pigs.
They all seem to have advantages and disadvantages, don't they?
I also can't say that the pump is always kind of the best option. I have to kind of put a plug in for people that are on injections, and kudos to you, because sometimes we hear that everyone should be switching over to a pump when I know quite a few people on injections that are doing just great as well. And I think we always have to remember that too, that, you know, more technology isn't always better. And I think Laurel recently put out a paper just looking at device barriers and seeing that one of the biggest barriers is actually just wearing a device all the time. I think that was my biggest challenge of even switching to wearing an insulin pump, is that it definitely felt like I always told my parents, it's like I'm a walking hospital. I'm like constantly connected to a tube and IVs. And even if it's tubeless, it doesn't matter. I'm always stuck to something. So, you know, some people that are doing injections and even no CGM, you know, whatever it is that works, as long as people are, you know, safe.
We even experiment and have published a kind of a hybrid approach where you take some basal insulin by needle and some basal by pump. And I think there's so many possibilities, and you have to find something that fits your lifestyle and your tolerance for wearables. Hey, Melinda.
Can I say something on that?
Hey!
Hi, guys. So I've been on the pump, but the last 3 months I actually switched to injections, and I'm actually liking it a lot more. I'm super active. I probably do almost close to like 2 hours of activity a day between like cardio and my weight training. And what my problem was, like, with my pump, I'd always put it kind of like in my butt or my legs because I don't want it in my stomach.
Yeah.
But I just found the absorption was like way too slow. So now when I do injections and I switch them around, I do them in my arms and like actually I do them in my shoulders. It's super fast and it's really good because before weight training, I do like high glycemic foods. And the absorption, like when I had my pump in, was way too slow, even if I pre-bolused. So now I'm on my MDIs and I have way better control.
I wonder if you're getting it into a bit of muscle melee, because, you know, you're quite muscular and you might be getting it into the muscle rather than the sub-Q, and it works a bit faster. So
yeah, that's
great
absolutely
great to hear that, and nice to see you.
You too, guys.
I think that's a big one though, like even just where we put our sites for our pump. Like for me, when I was a kid, no one really told me about rotating sites, and I was getting kind of scar tissue buildup, and it was really hard because I wasn't getting the insulin absorption. And I kind of noticed as soon as I switched my sites, I was all of a sudden like low all the time. This is actually another one we didn't really touch on with closed loop, is that the system also doesn't know in these kind of situations, if we're not changing our sites every 2 days like we're recommended to, and we start wearing it for 5 or 6 days, you know, not saying that, you know, everyone does that, but I know like some people have definitely done it where as soon as you switch, they kind of notice that all of a sudden their blood sugars will go low, because in those last few days where you should have been changing your site and you weren't really getting great insulin absorption, the automated insulin delivery was probably just ramping up because the insulin wasn't really getting into the body. So it is really important to just kind of always be changing our sites more often than not. But these studies now that are coming out with longer duration sites is also really helpful too.
Hey guys.
Oh, Joel, go for it.
Hey, Joel.
If you don't mind, thank you for the presentation, by the way. I was listening intently as I'm very interested in all things exercise and type 1. I'm MDI. I am curious, has anybody done any studies or analysis of, let's say, more of a, instead of categorizing the workouts as either, your primary categories, anaerobic, aerobic, or even more dialed into running, weightlifting, HIIT. I'm curious, have you guys done any analysis or studies of the heart rate zones? I've been into fitness now for, I guess, the last 6 years, and the reason I'm asking is the heart rate zone seems to drastically impact and affect my outcomes, where I can predictably go out for a run, maintaining a particular threshold for heart rate. If I can stay under a particular heart rate, I can trend flat for a half marathon, fasted, no carbs. But then you break that threshold, or you drop below a particular heart rate, and you plummet beyond control. And so then it's juice boxes or chocolate milk or whatever. So I'll stop rambling. I'm just curious if you guys have done any heart rate analysis.
That's such a great question, Joel. We have been thinking a lot about this, but I haven't seen too much as far as sophistication yet. But I think it's worth looking at. The large data set that we're collecting now, the subjects are wearing a Verily Health watch that gives us heart rates, and we can, if we know their age, estimate their zones. So we'll do that, but I don't know, John or anyone else, Jane, has anyone looked at, zone 1 versus zone 4 and metabolic responses? I think it's a great question.
Jane's still on the treadmill, my God.
I'm just walking, right? So I can keep doing this for hours. The one thing, the caveat, the warning I always give about heart rate, and especially when I'm teaching my undergraduate students, is that to try and assign thresholds to a population is really difficult. And if we're going to do anything by heart rate, it has to be individualized. And that means that involves the person who's using heart rate to know a lot about what their maximum heart rate is, where their threshold is. And that's not something that a lot of people know. And the reason why I'm adamant about this is because I'm a heart rate freak. Like, my resting heart rate is around 42 and my maximum's around 160. Right? So I'm kind of on that end of the spectrum that if you say, oh yeah, you should be running at 160 because that's zone 3. No, I'm falling off the treadmill puking at 160. And so that's where I'm really adamant that it has to be, precision medicine, as we're starting to call it.
Yeah.
Anything that's going to be heart rate related, it's going to be the individual that's dictating that heart rate, because there's also a level of efficiency in the activities that you do, where somebody who's a terrible runner has very poor technique is going to get a very high heart rate running at a certain speed, and then other people who are really efficient at it can go faster at a lower heart rate, and as you improve it, everything switches. And so there's so much variability involved in it that we have to be really careful if we're going to try and use that as a tool overall.
I also think one thing about heart rate that we need to remember too is, like, we need a good amount of data. Again, exactly like Jane said, it's so individualized, but we need a good amount of data to be able to draw a conclusion, because heart rate can also have like erroneous values. If you think about it with like stress causing an increase in heart rate, is that because of the exercise or because of the stress? And so having that kind of like actual conclusion of this is what the heart rate zone should be, but what it's contributed to, is it, a number of other hormones, just kind of situational. It's really challenging to be able to draw that into the wider population. But I agree, it's fascinating to me. Yeah.
Yeah, we have thought a lot about it. It's a really good idea, and we thought a lot about it, but I haven't made enough progress on it. I do notice.
And Joel, kudos to you.
I do notice that myself, because I use a Garmin wearable. I think it's a great idea, and I'm trying to sort it out even just for myself.
Me too.
Well, thanks for the replies.
I was going to say, you're going to see an increase in heart rate with temperature as well. So the longer your exercise session goes on, the higher your heart rate's going to get. And you're also going to see an increase in heart rate with dehydration. So the longer your exercise session, the more you sweat, the higher your heart rate's going to get. And your heart rate will increase if you're fighting an infection. Women will have variability in their heart rate throughout their menstrual cycle as well. So that's where it's just like considering every single factor. It can be a great tool, but you have to really know it well.
Absolutely.
Or
Thank you
just
so much, Dr. Jane.
or just throw it out. One of my buddies who's an endurance athlete just said, just forget about your heart rate, just go by feel and dial it in. Living in Winnipeg, so Joel's got a beautiful shot of Winnipeg in the background there. The first 2 weeks of summer coming from the winter, my heart rate's gonna be 15 beats higher just because I'm adapting to the heat. And so my coach is my own experience is just learn how to dial in what you think is intense and what isn't. So we published a little paper on moderate versus moderately intense versus slightly more vigorous, but we didn't show much in the way of differences. And then again, it was tough to dial that in for each individual on a treadmill. So using heart rate to dial in the exercise dose was not as simple because everything was different on every day. With that, I think we have maybe a couple more minutes left. This has been an awesome discussion. I know a lot of people have wanted this kind of discussion, so thanks for putting a lot of great data ahead of us, in front of us, so that we could have this discussion. From the peds world, last night, my son wanted to do laps around the house in the snow for no reason at all. We were doing some HIIT sprinting with our shirts off. We all had our shirts off, so I don't know what just thinking about Conrad, who's a parent of a young one with type 1, like how do we dial that in? Is CGM useful? Is it recommended for the little kids they don't have 90 minutes. They don't know 90 minutes is a week for them. So what do you recommend for younger kids in CGM or any kind of technology?
Thanks, John. What a great question. Since I've come to work at Stanford now, focusing on the little kids and just the pediatric population has kind of opened my eyes to a lot of, I was there once when I was, 7 and I was diagnosed with diabetes, didn't know much because still I'm learning a lot about exercise. One thing that we have found, and we've recently published a few papers on this, is that we're starting CGM at new onset. So basically within the first week of diagnosis, we're starting CGM. And now these are recently published papers that I can definitely share as well. It's been fascinating to see sort of the response. We actually are just in the process that shortly I'll be able to speak on because it's not published yet, but looking at kind of focus groups where we were able to ask the families sort of what their intake was or opinions were about starting CGM so early. Because one thing that we really advocate for in the US is actually getting these CGMs and getting them covered if we can. Whereas in Canada, I know this is like a huge challenge. Like there's so few people on CGM compared to what we kind of want. We want to push this as a standard of care. In the US, it's kind of the opposite here. We want everyone on CGM, and now we're getting all these, peds patients, especially at new onset, started on CGM, and it's been very positive. They're wearing the CGM, they're finding it very effective. We are doing sort of remote monitoring studies, so it's kind of part of a bigger trial. But being able to put these CGMs on the kids and kind of have if it was like a Dexcom app and having Dexcom follow for the parents is this added sense of security and just understanding. We've seen a lot of really positive things that have come out of CGM as well. So in the pediatric population as well. I would definitely say if possible, we know it's been really beneficial for our kids here.
I agree with what Dessi said. I just wanted to mention that, sometimes as a parent, that CGM relationship with your child with type 1, it just changes the dynamic sometimes in not a great way, because you can kind of see how your kid's doing and you can kind of get on their case, I think, a bit more if they're on CGM. And I've had some disastrous fights with my son based on his CGM values. So I think I need to have some good awareness about what are the risks in your relationship with your kid if they're on CGM. There's that whole issue of judgment and becoming glucose focused, over focused, I think. But luckily for me, Sam has started to embrace CGM more because he's now on the Control-IQ pump. So he kind of needs to wear the CGM for that pump to work properly. And I'm just trying to stay out of his business as much as I can now that he's a teenager. But it can cause friction between a child and their parent. Just
and I think one thing
diabetes does anyway sometimes.
Mike, I definitely agree. And you kind of brought up a great point. The difference for ours is starting at kind of 10 days after or within kind of the first week of diagnosis is there's so much to learn, right? So for that kind of stage, it's like the parents almost need it. They kind of, we've asked too, like, how was it when you were on finger sticks for the first couple of days before you started CGM? And they kind of say like, I can't imagine doing this forever. Like as soon as they switched to CGM, it's kind of like, you know, it changed everything. So being able to get that information at the beginning has been really helpful for them to just learn about what's happening. So nuance that may be a little bit different, but kind of as you've had diabetes for longer, I totally can see that, you know, toxic relationship potentially building with parents. And I know I never wanted my mom when I was a kid to be looking at my blood sugars. That was on a meter, but on CGM, it's totally different. Yeah, I get that too. But you're right, John. Pre-planning for exercise for a little kid is not really, it's not really feasible. And we do know that. So, you know, these are the kind of the situations where maybe CGM can help us so we can kind of see where are we going into exercise and what's kind of the situation, because pre-planning may not always be kind of available.
Okay, I think with that, we'll wrap it up. And just an open invitation to everyone for our hackathon. When we nail down some dates, we'd like to invite everyone to participate or reach out. So I put Andrew's email in there. Hopefully Mike and Dessi, we can twist your arms to come out and participate and help us design some studies and bring this into the next, you know, design a study yourself and work with some of our patient partners to invent the next part of your lab. So,
well, thanks, John, and congratulations for helping bridge that gap so well between researchers and patients. I really admire the work that you're doing, and the rest of your colleagues are. It's going to make a big difference, the work that you're doing. So thanks a lot.
Thank you, and really thanks for this amazing talk. We've been hyping you up for a while with our group, and I think you nailed it. So we're really grateful. And there's a few people that weren't able to make it who have connections to your lab as well from Toronto, who are deeply involved as patient partners here.
Great. Well, I'm happy if you share the recording. Whenever Dessi speaks, it has to be recorded because it's always so good.
Good.
Yeah, right. Thanks for having us. I really appreciate it. Even just seeing everyone and the familiar faces and new faces as well. Thank you guys for showing up, really.
And thank you everyone for coming. We really, really appreciate it. So take care. Have a great weekend. Bye-bye.
Bye.